Hey guys, Dr. Carmen Bryant here with Nursing School 911.net, and in this video we are going to be talking about chest tubes. So we're going to talk about some of the indications, some of the conditions in which require the placement of a chest tube, and some of the assessments that you're going to need to do if you have a patient with a chest tube, and then some of the troubleshooting things that if you have a chest tube going bad, and just, a little bit of the pathophysiology of how chest tubes work. So forgive my artwork here, but what I've drawn is a chest tube. So you may or may not hear chest tubes is referred to as wet or dry. Every single chest tube that I've ever had on any patient I've taken care of, either in practice myself or with students, has been of the dry seal part. So I highly doubt that wet seal chest tubes are still being used, especially where I'm from. I'm from Tennessee, so I'm in the Southeast. So what I'm talking about here is all dry seal chest tubes, okay? The Plurivac system is probably the most popular system. So indications for chest tubes. You'll hear of chest tubes being placed for reinflation or re-expansion of lungs when a pneumothorax is present. Chest tubes are placed to drain pleural effusions, or when there is fluid that has built up within the pleural space, the lining of the lungs. Typically, those types of chest tubes are going to be laterally placed chest tubes. You will see mediastinal chest tubes or chest tubes placed here following CABG or coronary bypass surgery to prevent cardiac tamponade. So when a patient undergoes CABG and the surgeon is, surgically opening up that patient's heart, that causes just a natural inflammatory response, and with that inflammatory response as part of the healing, there's always fluid that migrates to that area. So the surgeon is going to place that mediastinal chest tube there to prevent fluid from gathering in that pericardial space and causing cardiac tamponade. So those are the most common reasons that you'll hear of a chest tube being placed. So, basically we're either draining air with a pneumothorax or we're draining fluid. Okay, so these are the basic parts of your dry seal chest tube. So the first part that I have labeled over here is the part that goes to the patient. So if you ever assist with the insertion of a chest tube, like in the emergency department or something like that, you'll see that these jokers are big. They are like 16 French. And so if you are assisting with that, you definitely want to, if it's not emergent, obviously we're going to get consent, and we're obviously going to pre-medicate our patient, because these do hurt going in because they are large. So at the very tip of the chest tube, the end, the portion of the chest tube that is inserted into the pleural space is kind of pointed, and there are holes in the tube, and that is what is going to allow for the drainage of the air or the drainage of the fluid. So this is coming from the patient, and whatever it is that we're draining, if it's air or fluid, it's going to collect here in our collection chamber, okay? And so this, whatever's collecting in the collection chamber, if it is fluid, that is counted in our intakes and outputs. So we measure I's and O's typically every 12 hours unless it's indicated more often. So we mark chest tube drainage every 12 hours, and we count that as part of our output. And so that gathers here in the collection chamber. What I have drawn here is just a little tab. You'll see that that's at the base of the chest tube, and it just kind of helps keep the chest tube in place and upright. Typically, you'll see a piece of tape over that tab to make sure that the chest tube doesn't get kicked over or knocked over in the floor or something like that. So moving over to this side of the chest tube, this part right here, I've got as labeled tube suction. So you'll have the tube that's going to the patient, and then you'll have another tube, a connector tube that is connected up to the wall regulator. You'll have, you need to have that ready, if you're getting a report on a patient, and they're coming up with a chest tube to suction, you need to make sure that you've got your wall regulator in there, and already hooked up and ready to go, because this part is what's going to be hooked up to the wall regulator. You're going to turn that wall regulator onto full suction, okay? But that wall regulator is not what regulates the amount of suction that is placed on the patient. What regulates that in this type of system, in the dry seal system, is the suction regulator. And you'll see that on this system, and it looks a lot better than what I've drawn. But it's like a little dial, okay? And standard protocol is for you to dial that suction up to 20 centimeters of suction. And so that's what I've got here. So again, the connector tubing that's connected to the wall regulator is dialed up all the way to full suction, but the suction amount is actually controlled here by this really simple suction regulation device, and it's dialed up to 20 unless otherwise specified by the provider. Right underneath the suction regulator, we have the suction monitor, and what you'll see there is a little clear window, and if everything's hunky-dory and suction is working properly, then you'll see a little orange bobber in that orange window. And that tells you that the suction is working fine and everything's great. Then we have here the water seal chamber. Now, I know you're like going, okay, you said that this is a dry seal or a dry suction device, and it is, but still, we still have to have a water seal chamber. And it is always filled up to 2 centimeters with sterile water. And what this water seal chamber does on this device is this acts as a one-way valve, okay? So when your patient is inhaling and exhaling, whenever they inhale, whatever that air needs to be trapped somewhere, right? It doesn't need to then go back into the patient, because that is totally counterintuitive to the placement of a chest tube. So this water seal chamber acts as like the negative pressure. It acts as the trap for, the air, the fluid, whatever that we're, trying to accomplish with the patient. So even though it's a dry seal device, we still have the water seal chamber, and we've always got to make sure that that water seal chamber is at 2 centimeters. If it starts to drop below 2 centimeters, then that can lead to problems with our patient. That can lead to not enough negative pressure being applied, and it can actually lead to a really serious potential complication of a tension pneumothorax, where air is allowed back into the pleural space. So you're monitoring that and making sure that that's at the level of 2 centimeters at all times. All right, so this is the device. These are the parts of it. And so now on the other side, I'm going to talk about the nursing care. And so I talked, just very, very briefly, if you're involved with insertion, you're going to be assisting the physician, make sure you have the kit, sterile gloves for yourself and for the physician. Obviously, your main role is going to be pre-medicating the patient, because it's a very painful procedure. But this is mainly focusing on the care of a patient that already has a chest tube in place. Okay, so obviously every 2 hours is the minimum that we're performing all these assessments. Obviously, we're listening to breath sounds on the patient every 2 hours. Okay, we're listening for a baseline, whatever it is that we're trying to accomplish here. If we're trying to re-inflate lung because of a pneumothorax, or we're trying to drain off effusion, we're listening for an improvement from the baseline. We're also looking at respiratory effort, respiratory quality. Is the patient, still breathing regular, and there's no accessory muscles being used, the quality of respiration, the work of breathing. We're looking at all of those aspects. We are going to look at that dressing. So the dressing that goes over the chest tube is going to be a Vaseline occlusive dressing, and then on top of that you'll see like an ABD pad. Typically we're not going to be changing that dressing, but rather assessing it every 2 hours, and we're making sure that that outer ABD pad is clean, dry, and intact. I've got that abbreviated here. We're also monitoring and feeling for something called crepitus. So when the patient first gets the chest tube placed, you've got this humongous tube being inserted into the pleural space. Air is inevitably going to escape out around that chest tube when that chest tube is initially inserted. That creates what we call crepitus, or subcutaneous emphysema, which is basically air that you can feel under the skin, subcutaneous, okay? So you'll be able to feel or palpate, they say, like Rice Krispies. And so that initial crepitus on initial insertion of the chest tube is 100% normal. So what the responsibility of the nurse there is to mark the amount of crepitus upon initial insertion of the chest tube. Where the problem lies is when that crepitus starts to enlarge, okay? So you have a certain amount of crepitus marked that's already there. You go in for your Q2 hour assessment and the area of crepitus is starting to enlarge. That is an important issue. That's a threat to the patient's airway, and the provider needs to be notified of that. So we are monitoring the water seal chamber. Like I told you, it has to be at 2 centimeters at all times to maintain enough negative pressure to prevent re-entry of air back into the pleural space. So we keep sterile water at the bedside of our patients with chest tubes. We're looking at the drainage. So we're looking, number one, at the amount, and we're looking at the appearance in that collection chamber. All right. Now, if we're draining a pneumothorax, there's not going to be drainage, right? Because we're draining air. If there is drainage and it's sanguineous drainage, and we're supposed to be reinflating because it's a pneumothorax, that could mean hemorrhage, and that's an issue that needs to be reported to the provider because that is absolutely not supposed to be there. But let's say we're draining a pleural effusion. That drainage initially will be sanguineous, or it will be red. Then it should turn to serosanguineous, which will be some serous mixed with some sanguineous. And then eventually it'll become serous. And that's just the normal flow of the changing of the appearance of the drainage. Also the amount. The amount should be decreasing daily. We want to monitor for hypovolemia. So any drainage like greater than 100 milliliters an hour, that's going to put our patient at risk for hypovolemia. So we're monitoring that amount. So over 100 milliliters an hour can lead to hypovolemia. When we are starting to think about removal of the chest tube, we want that drainage down below 100 milliliters in 24 hours. So once we've reached that, little amount of drainage, then we're going to start thinking, hey, maybe it's time to start doing some x-rays and some other tests and make sure that, hey, this chest tube's ready to come out. We're looking for bubbling in that water seal chamber. So intermittent versus continuous. Anytime you see intermittent bubbling on an exam, that is usually a-okay. Think about it this way. If, intermittently or occasionally you see a little bit of bubbling in that water seal chamber, it's cool because it's almost like the lung is kind of burping, for lack of better terms. And so that's fine. That kind of indicates, hey, all right, the chest tube it's doing its thing. It's doing what it's supposed to do. This is normal. There's a huge tube in this patient's lung. If it burps every once in a while, okay. Continuous bubbling is not okay. So that means that bubbling is just continuous. It does not stop. That means there is an air leak somewhere in the system. So we're going to talk about clamping that chest tube. So if you notice continuous bubbling, what you're going to do is you're going to clamp the chest tube very close to the patient and see if that bubbling stops. If that bubbling stops when you clamp the tube right there up close to the patient, then you know that there's an issue going on inside the patient, all right? And the provider's going to have to fix that, okay? Remember, never clamp the chest tube for more than 15 seconds. You can absolutely cause a tension pneumothorax. So we're only clamping to check for an air leak, okay? So we clamp it off right at the patient, air leaks or the bubbling stops, air leak is inside the patient. More than likely, the physician provider is going to have to come down, put a new chest tube in. So let's say it doesn't stop, all right? Then that means the leak is somewhere distal. It's somewhere down the tube. So you kind of work your way down, and it may just be like a little bitty hole in the tube or something that you can put tape around the tube, and that fixes the leak. That's much better than having to reinsert, the chest tube because there's an issue going on inside the patient, if that makes sense. So normal titling. Titling is where you're going to see that water chamber rising up when the patient inhales and fall back down as the patient exhales. That's a good thing. That's totally normal. I will add this. I teach critical care, so I have to mention when you have a patient on a ventilator, titling is going to be the exact opposite because a mechanical ventilator, it delivers positive pressure ventilation. Okay, so we breathe in, as there's negative pressure created, we breathe in, but mechanical ventilation is positive pressure ventilation. So when that vent gives a breath in, then you're going to see that water seal chamber go down. And then on exhalation, it will rise. Okay, so normal titling will be the exact opposite in a mechanically ventilated patient than in a patient who is breathing normally on their own. When titling stops, if titling stops, that could actually be a good thing. If the patient has progressed nicely through their healing process, that can mean that a scab has formed over that area where there was an issue, and that lung is actually healed. So the ceasing of titling could be a good thing, depending on your patient. Now, if your patient looks like a hot mess and they're breathing 38 times a minute and, they're satin in the 80s or whatever, and titling has stopped, obviously that's time to call the provider. That's not a good thing. All these things, think of it all in the context of your patient. One clear or one, isolated part of the chest tube, doing this or, this assessment finding alone does not tell the full picture. Think of everything in the full context of what's going on with your patient, okay? Next, I have the Vaseline gauze. So you want to have sterile water at the bedside, and you always want to have a Vaseline gauze at the bedside, because if that chest tube comes out of your patient for whatever reason, number one, it's a really bad day for you and the patient. Number two, if we don't do something quick about that, then air is going to be allowed into the pleural space and can absolutely cause a tension pneumothorax. So you're going to take that Vaseline gauze as quickly as possible, and you're going to cover that site and tape it on 3 sides only, because you've got to be where you've got to have that dressing taped where the patient can breathe in, but it needs to also be able to air to escape that chest tube incision site. So that's why we don't tape it on 4 sides, okay? If we taped it on 4 sides, then we're gonna create a tension pneumothorax because air is just coming in and in and in as the patient is breathing, but it's not being allowed to escape out that incision site. The sterile water, like I've talked about, not only do we need to continuously maintain that water seal chamber at 2 centimeters, let's say the system is still connected to your patient, but it becomes, dislodged from the, the drainage system itself, or, it becomes detached or something from, the drainage system. You need to immediately take that tube and place it in 2 centimeters of sterile water. Because again, if you've got a chest tube that's, still connected to your patient and it's not, connected or, maintained in anything that's going to maintain that negative pressure, you're going to still allow air to enter into the chest tube, which can create, again, a tension pneumothorax. So, there's one scenario if the tube totally comes out of the patient, that's your Vaseline gauze. Then there's another scenario if the tube, becomes dislodged from the collection chamber and you can't get it reconnected. You want to stick that tube down into 2 centimeters of sterile water and alert the provider immediately. Milking the chest tube, you'll see, this on exams and stuff. This is where, nurses might get tempted. They might see something in the chest tube that they don't like the looks of it, and they'll try to milk it, and that's going to increase pressures within the pleural space and can, you guessed it, cause a tension pneumothorax. So we're not going to milk the chest tube. Clamping, that's the last thing that I have here. Like I said, you're only going to clamp for a maximum of 15 seconds at a time, and we're only clamping to determine the source of a highly suspected air leak. Okay, so that kind of wraps up the indications, some of the pathophys behind the chest tube, the parts of the chest tube. I know my drawing wasn't the best, but hopefully you kind of get the idea. Maybe when you see the chest tubes in lab or something, it'll make a little bit more sense to you. But I hope this video has helped. Make sure you look around the site, nursingschool911.net. Lots of resources on there to help you out with your care plans, and there's some practice questions on there as well. Lots of other videos, and trying to just, add stuff weekly, if not daily. So again, just thank you for watching. Hope your semester is going great, and thanks.